and treatment planning in restorative dentistry.
Good afternoon. Thank you very much for coming and giving me the chance to talk to you this afternoon. There's an expression, fail to plan, then plan to fail, and this can be applied in dentistry, especially in restorative dentistry. What does that look like? Well, here's an example. Here's a patient who's had 2 implants placed, and it's obvious from whoever placed them that they weren't thinking of the final restorative result when these implants were inserted. This is probably because they didn't have enough diagnostic information to formulate a correct treatment plan. They didn't have a vision, if you will, as to what the final result would look like before they started this patient on their restorative journey. You can see the trouble the restorative dentist has in that when he's come to try and make abutments for these teeth, he's had to prep them back, so much so that these have been perforated. These implants are unrestorable. And the only solution for this patient is to remove the implants. So what's happened is these implants were placed where the bone was, not where the restorative result demanded. And because of that, these implants are going to have to be removed. And so you've taken what was an easy osseous defect to correct into almost a maxillofacial defect. So in other words, if you don't plan your restorations, you're going to end up with problems similar to this. And this is an expensive mistake both for the patient and the restorative dentist. How do you avoid failure? Well, in all aspects of restorative dentistry, and I'm sure it's the same for the other specialties, formulate a treatment plan. And formulating a treatment plan is important for simple restorations such as this 1-tooth implant restoration, or in a big reconstruction like this where you're taking or treating every tooth in the patient's head and replacing fixed restorations. How do you formulate a treatment plan? This is something that you would have been taught in dental school, and it's true for complex restorative dentistry as it is on your first day in dental school. We need to examine the patient. From our examination, we come up with a diagnosis, and from our diagnosis, we can formulate a treatment plan or treatment options for the patient. So how do we do that? Let's look at the components of the examination that are required for restorative dentistry. When I'm talking today, I'm talking primarily in general. So this is stuff these are techniques that you can take back to your practice. But I'm also keeping an eye on the examination that you'll sit. And some of the slides that are taken from this lecture will appear in some of my examination questions. And I'm trying to introduce you to the thought process behind these into formulating the correct answer. When you examine patients, the first thing to do is find out what's their presenting concern. What does this patient want? We need to look at their histories, medical, social, dental. We need to perform a clinical exam, examining the oral cavity and the site in question. We need a radiographic examination. And finally, we need to perform special tests, and these will vary from patient to patient. Medical history is very important. A useful classification is the American Society of Anesthesiologists classification 1 to 6. You should be familiar with this classification. Remember, common things occur commonly. But from a restorative periodontal surgical perspective, important conditions to be aware of or to know a little bit more about perhaps are things to do with bleeding issues, restorative dentistry, reflux and acid attack of teeth is important, so know about patient reflux conditions. Diabetes is an ever-increasing condition, and this can have important implications for periodontal disease and for implants and bone grafting. You need to know about the various medications that people are taking because these can impact some of the treatments that we can offer for patients. A good reference for the exam and for your practice in general is Medical Problems in Dentistry by Cawson. You should find out a little bit more about the patient's backgrounds. What are their habits? Smoking is very, very important when it comes to the treatment of periodontal disease, for the placements of hard and soft tissue grafts, and for the placement of dental implants. You should be aware of the immunological effects of smoking, how it suppresses polymorphonucleoleucocytes, the effects of cigarette smoke on bacteria, and on small vessel healing post-surgical treatment. You should be aware of the effects of periodontal disease. For example, in this case, an implant was placed in a patient with suboptimal oral hygiene, and within 4 or 5 years, the implant had failed, resulting in not the same defect that the patient had prior to implant placement, but a much worse defect, one that will not be amenable to repeat implant treatment. You should be aware of the patient's past dental history. This can have an impact on the treatment you're planning. For example, past orthodontic treatment may have an impact on the patient's tissue morphotype, which in turn can have an impact on the recession experience of the patient, which may cause problems if you're placing crowns in areas of high aesthetic demand. Orthodontic treatment may have influenced the length of tooth roots, which in turn can change the prognosis for a tooth as an abutment for a fixed partial denture. A past history of periodontal disease and treatment. Has this patient relapsed because this is refractory disease, or is this just a case of the patient's recurrent disease because of the patient's lack of maintenance? You should be aware of the patient's prosthetic history. A patient who presents with a bag of dentures such as this is probably not going to be satisfied by your efforts. In fact, the past dental history can give you an insight into the patient you're treating. Is this person reasonable, and can you satisfy them, or is this person someone who's maybe best referred to someone else? A good paper to look at to give you an insight into denture patients is Cowper's Difficult Denture Birds, where he divides up patients into different psychological types. When we move on to a clinical examination, obviously we look for pathologies, and any decent oral pathology textbook can talk about that. We look at the patient's temporomandibular joint. What's their range of motion? Are there joint pathologies? Is the patient able to open their mouth long enough to undergo the procedure you wish to undertake? Can they open their mouth wide enough to allow placement of an implant in a second molar site? We need to look at asymmetries. And this can have an impact on things like placement of crowns in the anterior maxilla, especially in highly visible areas. For denture patients, we might look at occlusal planes, center lines, and the soft tissue support. A not unreasonable question in an examination may be to identify some of the features you see on this photograph. Are these anatomical features well supported by the patient's denture? When we look intraorally, we look for pathologies. But the important things from a restorative point of view are the concept of restorative space, their soft tissue, and the hard tissue exam. If you're not aware of what restorative space is, it's the space available for the proposed restoration. And it's measured mesiodistally, coronogingivally, and intra-arch. So, for example, you can see in this particular patient here, if this tooth is to be lost, can an implant be placed here? Is there enough space to allow placement of a dental implant? Is there enough space here to place an implant-supported crown or a tooth-supported bridge? Do we have enough restorative space, or do we need to do something to the remaining occlusion? A lack of restorative space will limit your options and may require additional treatment. Of crucial importance is in large reconstructions or indeed in denture manufacture. For example, if a patient is going to have a 2-implant overdenture, the question is there enough support or is there enough room for the attachments on top of the implants? So in this particular case, if we take the top blue line as being the occlusal plane, we need a minimum of about 2 millimeters thickness for acrylic. We need a certain thickness depending on the attachment we use, and depending on how the implants are placed, how much space they occupy above the tissue. If that dimension is greater than what we have, then we won't be able to successfully place an implant-supported overdenture. When we look at a periodontal examination, there are a number of things to consider. There's the patient's tissue morphotype, which we'll talk about in a minute. There's recession and keratinized tissue. These are going to be of importance if fixed restorations are going to be placed. There's the inflammation in the tissues. What's the tissue color? Is there bleeding on probing? And what's the patient's plaque score? Patients can be divided into thick, average, or thin tissue morphotypes, and this was described by Coyce, and it's dependent on the underlying bone. So, for example, a thin tissue morphotype here might be more prone to recession, a thicker tissue morphotype may not. In this particular case here, if the patient was to be flapped, you would find that there were dehiscences and fenestrations on the facial aspects of these teeth. A lack of underlying bone will result in a thin tissue morphotype and a patient who's much more susceptible to recession. And you can see the devastating consequences happened here for crown placement and subsequent recession. A thick tissue morphotype is the reverse. When these areas are flapped, you find thick amounts of bone on the facial aspects of teeth. These areas are not prone to recession and may require crown lengthening surgery if they're to be restored. A question might be asked is, how would you determine the difference between someone with a thick or thin tissue morphotype? A simple test described by Houshman involves placing a periodontal probe into the gingival sulcus, and surprisingly enough, if you can see the probe through the tissue, then the patient is deemed a thin tissue morphotype. You should be aware of periodontal disease and how to interpret the readings of a periodontal exam. You may use a PSR, but a full mouth probing charting will give us more information. You should be aware of what plaque, bleeding, probing, mobility, furcation, recession scores indicate. For example, someone with a high plaque score but a low bleeding score may have just missed their brushing last night and the night before. Someone with a high bleeding score, a high plaque score, may have just poor oral hygiene. When we look at a hard tissue examination, you need to see, is there caries present and is this controlled? Attempting to put 3 or 4 crowns in this patient's mouth with active caries is going to be an exercise in futility. The disease process has to be controlled. We need to look at the teeth present. Where are they? So, for example, the second premolar tooth here may be an excellent abutment for a 3-unit bridge, but because of this long span here, this premolar tooth may not be. You should be familiar with the concept of Ante's law. Although not a law, it's been a guide that has served our profession well over the last almost 100 years. The position of teeth is important too, as is the crown-root ratio. Is this tooth a better abutment because of how much of the crown is above the level of the alveolar bone? When we come to look at the teeth themselves, what is their restorative history? So a tooth like this, for example, with an MO temporary restoration placed, how would you restore this tooth if it was root treated versus not? And finally, you need to look at the occlusion. And occlusion is something, when I've examined in past examinations, I almost see the life die in people's eyes when we ask them about occlusion. And it seems to be something that's made more complicated than it should be. You need to be aware that there's a difference between occlusion and articulation. So occlusion is the static interrelationship between the teeth, while articulation is the kind of static and dynamic contact relations between the occlusal surfaces of the teeth during movement and function. There are many different occlusal concepts that have kept many dentists awake at night for long periods of time. However, a simple thing to remember, or simple concepts to remember, are the concepts of centric relation versus MIP, maximum intercuspation position. What we want in either of these positions is even simultaneous point contacts. For fixed restorations, we want anterior guidance. In other words, the mandibular incisor teeth are running off the back of the maxillary canine or maxillary incisor teeth. We want no interferences. You should be aware of the consequences of interferences. For example, they may result in broken restorations or pain in the temporomandibular joint. Once you've carried out a complete examination, radiographic examination is important, and we have available to us intraoral radiographs, bite wings and periapicals, and these can show us such things as bone levels around the necks of teeth, apical pathologies present, and also the condition of restorative margins. A PANOR or PANORX can show us things like the presence or the location of the inferior dental canal and the location of the sinuses and whether they are pneumatized or not. Of increasing importance is the cone beam CT scan. You should have some idea of how to read these. These give us the third dimension. We're able to see the thickness of the alveolar ridge. Mentioning cone beam CT scans, you should be aware of what's required. If we've gone to the trouble of taking a cone beam CT scan, this is usually done because implants are being contemplated, or certainly in restorative dentistry. A not unreasonable question, therefore, is how much bone one needs to place a dental implant. So there's controversy at the moment in terms of how much height and thickness are required, but a good rule of thumb is 8 millimeters or greater would be a reasonable bone height for an implant, although there is a controversy now with respect to short dental implants. We need a width of about 6 to 7 millimeters for a 4 millimeter diameter implant interproximally. And we need a bone depth which is changing because the diameters of implants are changing, but a reasonable bone depth might be the diameter of the implant, let's say 4 millimeters, plus 1.5 millimeters on either side, so a reasonable thickness might be 7 millimeters for a standard 4 millimeter diameter implant. Also from this cone beam CT scan, you should be aware that density can be determined, although not particularly accurately using the Hounsfield scale. Once we've completed our radiographs, special tests can be ordered. And these can be very simple, such as vitality tests. A not unusual question might be to present a slide such as this one and ask what is the next step. And of course you all know that that would be to make either a radiograph or to test the vitality of the tooth with cold spray. And this can tell us or give us some indication of the pulpal status of that tooth. Other special tests to consider are the making of study casts. And study casts can give us much more detail than we can see just intraorally, but the greatest diagnostic yield can be harvested if the casts are mounted. Therefore, you should be aware of what jaw records are needed to place a cast or a set of dental casts in an articulator. We need a Facebook record and an interocclusal record. What the Facebook record does is it relates the hinge axis to the maxilla. In other words, it positions the maxillary cast in the articulator. You should be aware there are two sorts of Facebook. There's a kinematic, very accurate Facebook, but not used generally or frequently. And there's the average Facebook, which is probably what you learned in dental school, a whip mix type Facebook or an ear or a spring bow or whatnot by Hanau. You should be aware that the arbitrary Facebook, although it's based on averages, is quite accurate. So, for example, most individuals, when we use an arbitrary Facebook, are within 1 to 2 millimeters, or the hinge axes they're within about 1 to 2 millimeters of the hinge axis. If you have a 5 millimeter recording error, it results in a 0.2 millimeter error at the second molar. Now, I wouldn't remember that fact, but what we're trying to show is that using semi-adjustable articulators in practice may require a small degree more adjustment of your restorations when they're placed, but that's within the margin of error and doesn't require much adjustment once they're placed. These can be used for both fixed and removable prosthesis. When we make an interocclusal record, the first thing we need to decide is where are we placing the mandible. So, for example, if we're placing 1 or 2 restorations, we may conform with the patient's occlusion and we might mount them in maximum intercuspation position. If we're undergoing a reconstruction, we may reorganize the patient's dentition, and therefore we might use CMMO or centric jaw relation. Whatever position we use should be repeatable and measurable. Finally, once the casts are mounted, it may require that we use a diagnostic wax-up, and you should be aware of what you can achieve with a diagnostic wax-up. The diagnostic wax-up can determine the end result of treatment. It can show us things like restorative space, what sort of occlusal design we're going to use. Are there tissue deficiencies? And diagnostic wax-ups can be used not only for multiple cases where you're planning a large reconstruction, but in this case here you can see, for example, the width of the proposed tooth, the height of the proposed tooth, that there's a defect up here tissue-wise, and that something may have to be done to the mesial aspect of this tooth to gain a more ideal or optimal restoration. It can give us input on the aesthetics as well. Here's an interesting case. A patient presented. She had a large diastema between her central incisor teeth. I don't know if you picked it up yet. And the dentist's restorative solution was to place a 3-unit bridge between her central incisors, which she found very unattractive. So what we've done here is she was about to undergo orthodontic treatment, close it after we removed her old bridge. And what we've done is we've presented her with 3 different options that could be achieved using various combinations of restorative dentistry and orthodontic treatment. Once we have our diagnostic information, you should be aware of the concept of a differential diagnosis, which is the process of identifying a condition by comparing the signs and symptoms of all pathological processes that may produce similar signs and symptoms, and then finally arrive at a diagnosis, in other words, a determination of the nature of disease. So 2 examples before we close. In this particular case here, a question might be, what is your differential diagnosis? Well, what's the examination results first? What do we find? Well, we have 11 millimeter probing depths, we have bleeding on probing, the tooth is non-vital, there's some bone loss, and there's some pocketing on some of the other teeth. A differential diagnosis might be a localized periodontal disease, an endodontic lesion, a vertical root fracture. And at that point you might be asked to hazard what do you think it is, and a not unreasonable answer might be an endoperio lesion. In terms of periodontal treatment, you should be able to, as we discussed earlier, interpret a periodontal charting. In this particular case here, we have a patient, 47-year-old male, non-smoker, a high plaque score, high bleeding and probing score, and generalized pocket depths. And there are interferences during excursive movements. So a not unreasonable diagnosis might be chronic generalized adult onset periodontal disease with trauma from occlusion as a possible cofactor. Therefore, in conclusion, examination and diagnosis are essential elements in patient care. Remember, common things occur commonly. So if you're in the exam and you're asked for an opinion, it may be very exciting to give a diagnosis that's only been recorded once or twice in the past 1,000 years of human history, but it's probably unlikely that it's going to be occurring with your patient. So remember, common things occur commonly. Be familiar with reading test results, radiographs, and other diagnostic tests. The x-rays that I pointed out, the radiographs I talked about earlier, are not unusual radiographs. You should be able to look at a PA, a bite wing, or panoral, or indeed a cone beam CT scan and give an opinion as to what you think. Give a differential diagnosis as opposed to the first thing that pops into your head. And finally, plan your work, then work your plan. Thank you very much for your time, and hope you enjoy the rest of the afternoon.
Thank you very much, Paul. Paul has, in fact, set up really the next four speakers brilliantly by touching on so many salient topics, and I'm going to be taking up the running now in terms of removable prosthodontics, and I'm going to be talking about 5 topics which sound basic but are integral to understanding things. Classification of RPDs, RPD design, and then retention, support, and stability. And sometimes retention, support, and stability get rolled into one, but I think it's prudent to be able to differentiate between them. Okay. So, Edward Kennedy, classification. If I said to you, do you know the classification upside down, inside out, back to front? Would the answer be yes? It's something that we have to know upside down, inside out, and back to front, because it helps us discuss and it also helps us to design. Class 1, bilateral distal extensions. Class 2, unilateral distal extension. Class 3, bounded saddle. Class 4, the only edentulous space is the anterior one. That's one that people commonly get muddled up. They'll say, oh, it's a Kennedy 4 modification something. It can't be, because it's the only edentulous space. The rules. After all the extractions are done, third molars, rule 3, third molars not considered unless present. So if they're there, it's part of the classification. And then modifications. And then, like I said, knowing where does class 4 fit into the whole equation. 1 and 2 take precedence over it, and 3 takes precedence over it. So, Kennedy 1, bilateral distal extension. Kennedy 2, unilateral distal extension. The 7 isn't being replaced, so therefore it's a Kennedy 2. Kennedy 3, or Kennedy 2 modification. You do it from the Kennedy 2. The Kennedy 2 is the guide, is the overarching one. So here you might be tempted, is that a Kennedy 3? No, it's a Kennedy 2 mod 1. Here, this is a Kennedy 2 mod 1. Those two examples are the same classification, even though they look completely different. But if you apply the rule, it'll make sense. Kennedy 3, bounded saddle. Commonly, the major connector in a Kennedy 3 will be a palatal strap. This is an open ring that you see here, but commonly it'll be a palatal strap, particularly if there's a modification. They're an example of palatal straps. Palatal straps should be 12 to 15 millimeters wide. The one on the left is only about 7 millimeters wide. Kennedy 4, just the anterior space. Don't get tricked into thinking this is a Kennedy 2 mod 1. Okay? So, in your mind, just see, do you know what the answer is? So that would be a Kennedy 4. That would be a Kennedy 3 mod 1. That would be a Kennedy 3. This guy up here, Kennedy 1, Kennedy 2 mod 1. This guy here, Kennedy 2 mod 1. This guy here, Kennedy 2 mod 2. You all know that. Okay, well done. So second, RPD design. What do we need to design a partial denture? By the way, who should design the partial denture? The dentist should design the partial denture, because only the dentist can do the clinical examination. The laboratory have an inanimate cast. Only the dentist know if that tooth moves. The tooth never moves on the cast. So we have to do the clinical examination. Study casts and the surveyor. What is a surveyor? It's a paralleling device. This is what it facilitates us to do. We can't design a partial denture without a surveyor. Gives us the path of insertion, retentive undercut, soft tissue undercut that maybe we have to utilize in our path of insertion. It helps us get rid of dead spaces, black triangles, and then it brings all those aspects together. So what are the steps in an RPD design? These are the steps. Path of insertion, which utilizes the guide planes, major connector, support, retention, and then when you've done that, is there anything you can eliminate to streamline your design? So, path of insertion, guide planes. This is what we want. We want that there is no space between the distal of the tooth and where the RPD will go in, the mesial of the tooth and where the RPD will go in. If there's a big undercut in there, you might consider doing a tooth preparation. Maxillary major connectors, these are the 5 types. Okay? This is what they look like. Full palatal coverage. You do that when you have very few teeth left or when you're going to be losing some more teeth. AP ring, very common design when you might have something like a Kennedy 4 and you want minimal coverage of your palate. This is called a swing lock. Swing lock is utilized when you have just anterior teeth that are very proclined and you won't be able to get clasps on them. You have a little gate that closes around the labial of them. Palatal strap, like I said, 12 to 15 millimeters in width. Horseshoe. Horseshoe is a very commonly used major connector. It should only ever be used if you have distal abutments. If you don't have distal abutments, if you say had a Kennedy 1 or a Kennedy 2, never use a horseshoe. It will extract the distal abutments. When would you say this is most commonly used in practice? It's most commonly used in Kennedy 1s and Kennedy 2s, the very time it shouldn't be used. So horseshoe major connectors, Kennedy 3s. Or you could consider in a Kennedy 4. These are the lower major connectors. So we've already got our path of insertion. Now we're trying to connect everything. Lingual bar, sublingual bar, lingual plate, split plate, labial bar, swing lock. How much space do you need for a lingual bar on the lingual of the lower anterior teeth? You need 8 millimeters. 3 millimeters of space from the bar to the floor of the mouth, 4 millimeters of space for the bar, and 1 millimeter space to the gingival margin. If you don't have that, you cannot use a lingual bar. It will produce repeated ulceration. In that situation, you would use a lingual plate. So we have a lingual bar here. How many millimeters do we need for that? 8 millimeters. If we don't have it, we would consider lingual plate. Or in a Kennedy 1 or a Kennedy 2, we might consider a lingual plate for indirect retention. Split lingual plate. Areas where you have diastema between teeth. History of perio, you want minimal coverage. Labial bar. When would you use a labial bar? You'd use a labial bar if the lower anteriors are very retroclined and you're not able to get your major connector in. So we spoke about a swing lock in the upper when they're proclined. We talk about a labial bar when they're retroclined in the lower. Support, rest seats. Very, very important. In Kennedy 3s, the rest seat are put adjacent to the edentulous space. In Kennedy 2s or Kennedy 1s, the rest seat is put mesially. If it's put distally, it will help to extract the tooth. Distal extensions, the rest seat is put mesially. It directs load onto the abutment tooth, it resists movement of the prosthesis downwards, Horizontal stability, and I think the one that people forget all the time, it maintains the retentive component in the proper position. If the denture isn't supported vertically, your clip is going up and down. So very important. What should the dimensions of the rest be? The rule of thirds and fifths. 1/3 of the intercuspal width, 1/5 of the mesiodistal length. And the same if you're doing inlays or anything into your restorations, the same dimensions, into your abutments, the same dimensions occur. There are two types of retention, direct retention and indirect retention. Direct retention is offered by retainers. There are two types primarily, occlusally approaching and gingivally approaching. Which offers more retention, an occlusally approaching clasp or a gingivally approaching clasp? A gingivally approaching clasp. And the way you remember that is if you were pushing a wheelbarrow up onto a footpath, would it be more difficult to push it up or pull it up? Gingivally approaching pushes. It's more difficult to push a wheelbarrow onto a footpath. There is more resistance and retention. So gingivally approaching clasps have more retentive capacity. Indirect retention, anterior to the fulcrum line on a partial denture, say in a Kennedy 1 or 2, everything that is anterior to that at a right angle offers indirect retention. So resistance to displacement away from the tissues, that's indirect retention when the saddle comes up. We must have the correct undercut. There are different amounts of undercut for different types of clasp. A cast clasp, 0.25 millimeters, wrought clasp, 0.5, and wrought gold, 0.75. That's important to analyze. How would you know what undercut you have? Through the use of your surveyor. Distal extension partial dentures. Special category of partial dentures. You've got that from what I've been describing. So what's the most favorable clasp design in mandibular Kennedy 1 partial dentures? What's the most favorable clasp design? 3 letters. RPI. Great. So the RPI concept, so what does it allow us to do? What is it? R stands for mesial rest. It directs the axis, the loads down the long axis. Proximal plate, the proximal plate should be slightly lingual, and just the head of the plate should be just at the height of contour, so that as the person bites and this goes down, the denture can move in this direction. The clasp, which is on the mid-facial, as the denture goes down here, the clasp goes down and forward. It is disengaging from the tooth. You never put an I-bar on the distal of the tooth in a distal extension partial denture. Never. It's always mid-facial or mesial. So the advantages of the RPI, the proximal plate and the I-bar move away from the tooth like I was describing there. The mesial minor connector and proximal plate eliminate reciprocation needs. I-bar is more aesthetic. Minimal contact, caries-prone individuals. The I-bar is better than an occlusally approaching, and it eliminates the class 1 lever. Retention, support, and stability for complete dentures. Retention, resistance to displacement away from the tissues in a vertical direction. There are 3 methods: physical forces, muscular forces, and mechanical retention. We forget about these. We think of suction when we talk about retention, but it is made up of all these aspects. So principles for physical forces: maximum surface area, close adaptation, and peripheral seal. So adhesion is a physical force, cohesion is a physical force, interfacial surface tension is a physical force, capillary attraction is a physical force, and atmospheric pressure is a physical force. So adhesion, unlike molecules, the saliva to the mucosa, the saliva to the denture. What's critical for this? We must have maximum surface area. Cohesion, physical attraction of like molecules, so within the saliva. What's essential for this? We need thin saliva. Thick, ropey saliva, disadvantage. What's the key? The key is surface area covered. You must have maximal surface area for good retention. Capillary attraction, like in the capillary tube and the meniscus and all that business, force is directly proportional to the area covered. So you're getting the message, area covered. And atmospheric pressure, this is like the get out of jail one. It just gives you that extra bit of holding the denture in place. And what's it directly proportional to? Surface area covered. Okay. The muscles. We need the denture to work with the muscles. So things that challenge good retention. If the border of the denture isn't in good harmony with the muscles. If it's overextended or underextended. Friendly contours. This area in here, we're talking about a lower, so it's not strictly retention, it's more stability, but same concept. If we don't have a nice contour there, the tongue will want to lift the denture. So harmony with muscle forces. So poorly contoured dentures reduce retention, stability, support. Mechanical retention, very important to look at an edentulous cast. Just like you look at undercuts on a dentate cast, look at an edentulous one. So if we take this case, for example, this patient, huge big maxilla, right? You would think it should be easy to make a denture for that person. This was the denture that had been made for them. The denture has minimal extensions, so we know it's not going to have maximal surface area. We have a lot of papillary hyperplasia, denture stomatitis, and it's because the dentist wasn't able to get the denture to go home. The undercuts were too big. So the solution, you can do surgery, or you can use a path of insertion where you might come in from one side with the denture, in like that to that undercut, and then rotate up. So use of undercuts can really help. Paul spoke about disease in diagnosis. Probably the 3 or 4 you would need to know in terms of removable prosthodontics, inflammatory papillary hyperplasia, denture stomatitis, angular cheilitis, and denture granuloma. Those would be 4 common things that you would notice. Oh, sorry, there's a 5th one. Yeah, those would be the common things that you would be asked about soft tissue lesions in complete dentures. How do you test for retention, support, and stability? This is how you test for retention. Pull on the canines. If it doesn't come down, you have retention. Doesn't mean anything other than that. Tip at the front, that's the post-stam. So what do you think of the extension of this denture yourself? Well, when we look at the tissues here, that's the outline of the denture. That's the fovea palatini there, so this denture is underextended. Will it have maximum retention? No. Is surface area a big deal for dentures? Huge. Okay. This person says my denture is moving. What do you think of the extensions of it? It's probably underextended here. Okay. So we put a little bit of green stick on to do a test. It improves the retention. We convert the green stick into acrylic, and the denture is improved. Why was it improved? Because we improved the surface area. Okay. This is a famous Gaelic footballer coach in Croke Park cheering his team on, and his denture was displaced. Why did that happen? Because if you look very carefully, you can see it's a bit underextended, just there. Okay. So support, resistance to displacement in a vertical direction. It has to do with 2 things. It has to do with the adaptation of the denture and the condition of the tissues underneath. How do you test for it? You push on the first premolar. If the denture rocks, there's poor support. If the denture is solid, there's good support. If the tissues underneath are mobile, it may move, but it won't rock. It'll stay with the tissues. So the flabby ridge. So you can see me pretending I have some video on my footage there, and that's that ridge moving. So if you see that, you have to compensate for that by perhaps changing your impression technique. A mucodisplacive technique, such as using alginate, will scrunch up that tissue. It will produce sores. It will accelerate resorption. It will cause disharmonies. So you want a mucostatic impression material, particularly in the area of where the flabbiness is. Final thing, stability. There are three things that control stability: the borders, the occlusion, and the tooth position. Okay? So, how do you test for stability? You know how to test for retention, you know how to test for support. How do you test for stability? You go up to the buccal sulcus, you pull out the denture, and you pull out the buccal tissues, and if it doesn't knock the denture down, then you have good border stability. I spoke about three things: borders, occlusion, and tooth position. You do the same, and on this one you pull it out, and this frenal attachment is knocking the denture down. So this denture is overextended in that area. So if a person comes in and says, my denture is loose, and you say, no problem, I will reline your denture, but if the denture is already overextended, will you improve the situation or will you make it worse? Okay, so you have to decide, is it retention, is it support, or is it stability? That's the issue. Again, friendly contours. I repeat that. Eamon Croak, a dentist here in Dublin, is superb at contouring his dentures, and it's like as if they were just grown in the person's mouth, and he's always talking about this context. Occlusion. So this lady is wearing an upper denture and a lower partial denture, and she describes that her upper denture is loose. Now, it could be loose for a lot of reasons, but what one reason do you think it might be loose? When I bite my teeth together, my top denture is loose. What might it be? It might be that the canine here is knocking off the top tooth, the denture, right? So it's an occlusal problem. And you ask the lady to tap together, and the denture moves, and the denture moves. You test for retention, it doesn't come down. You test for support, it doesn't rock. So what are you going to do? Well, you might level the canine, but if the vertical dimension is correct, you might add some acrylic instead on either side. Obviously, you can make new dentures, which would be the optimal, but you can add acrylic, and now that top denture doesn't move. So you've done a diagnostic test to work out the problem. Opposing natural teeth against a denture, very difficult to make the upper denture stable. What might this cause? There's a condition, something syndrome, combination syndrome. What are the 5 things in combination syndrome? Anterior flabby ridge, papillary hyperplasia, pendulous tuberosities, roller coaster, lower occlusal plane, and resorbed posterior mandibular ridges. Okay? Look it up. Okay. So if you have lower anterior teeth, consider making a partial denture at the lower back teeth to reduce that rocking and rolling. How do we control occlusion? Well, we can do remounts, we can do equilibrations, and the time you might correct the occlusal problem is at the try-in, after you process the denture in the laboratory, at delivery of the denture, and if the person comes back and they have soreness on the ridges, not in the sulci, but on the ridges, it's very commonly an occlusal problem. So consider doing an equilibration. So what's the rule for equilibration? Where do I adjust? The red dot or the blue dot? It doesn't matter what color the dot is, it matters where the dot is. So in centric, Paul spoke about centric and MIP and that. In centric in dentures, going straight up and down, you adjust the fossa, only the fossa. You've heard of the bull rule, you've heard of the Lubbock rule. Bull rule, buccal upper, lingual lower. When you're doing eccentric, working side, you use the bull rule. You equilibrate the buccal of the upper and the lingual of the lower. And if it's on a non-working side discrepancy, you use the Lubbock rule, lingual upper, buccal lower. Many times students, when I would say, where do you adjust on a denture, they'll say the bull rule. That's only working side. So always start from centric. Adjust the fossa. 3 contacts on each side if possible. So what are the controllable things in terms of stability? Well, we know we can control extensions by good impressions. We don't want overextension. We don't want underextension. We can control occlusion by equilibration and careful jaw relations. Tooth position, where we put the teeth. If they're in the wrong place, the muscles will lift them up. And we can control fit. Fit important in terms of close adaptation, retention, etc. Tooth position, so where should they be? If they're too far labial, the mentalis will lift them up, the orbicularis will knock them down, etc. So let's get them right. What are the guidelines? These are the guidelines. The upper front teeth should be 10 millimeters in front of the incisal papilla. If they're too far out, they'll get knocked down. If they're too far in, the person will look collapsed. Where should the lower anterior teeth be? The necks should be coming out of the sulcus, If the necks of the lower teeth are too far forward, we're going to have a situation where the denture is getting displaced. So we want the necks of the teeth coming out of the sulcus. This is the most common denture setup problem that we see all across the board. So in this situation, the teeth are out here, the sulcus is back here. What do you think might happen this denture? It might lift up every time they smile with mentalis. So that's where the sulcus is. This is where the necks of the teeth are, out too far. This person, their lower denture jumps up when they're talking. What do you think might be causing that? Overextension? No. Lingually, it could be. But I would say in this situation, when they're moving their lips like that, just labially. But it can be legally, and you would test by having the tongue move to the left, and if it lifts up on the right, it's overextended on the right. And you move the tongue to the right, and if it lifts up on the left, it's overextended on the left. So you don't want a situation when a person comes into your surgery who you've made the denture for, and they say, hi, and then the denture drops down. So in this situation, the upper front teeth were out too far and are getting dropped down by the lip. Back teeth should be in Pound's triangle. This is Pound's triangle, from the base of the retromolar pad to the canine. If the teeth are in that triangle, the tongue and the modiolus and the buccinator are happy. Keep the teeth in the triangle. Keep the teeth over the ridge. Halfway up the retromolar pad, that's where the occlusal plane should be. Why is that? Because that's where your teeth are in your mouth. If you put your tongue from the back of your 6 and 7, you're halfway up the retromolar pad. If we get above that, we cause instability. We should be level with the lateral border of the tongue. Halfway up the retromolar pad, that's where the teeth should be going. 6, 7, halfway up the retromolar pad. So we've two more slides. What do you think of this? This is the retromolar pad here. What do you think of the occlusal plane here? Too high or too low or perfect? Too high, yeah, causes instability of the denture. That's where it should be. How far back should the teeth end? My lecture should end now. So how far back should the teeth be? Should the teeth be back here? Should the teeth be here? Well, the teeth should end where the slope starts going up. By having a tooth above the retromolar slope, when the patient bites, it's like a ski slope. The denture is getting shifted down that slope. So keep the teeth just above the flat part of the ridge. And in doing that, you will contribute and continue to have good retention, support and stability. Thank you very much. Our next speaker is Dr. Jerry Cleary. And Jerry is a prosthodontist and is in practice in Dublin and also teaches in the Dublin Dental School. And Jerry will be talking about fixed prosthodontics, and that will continue on from Paul Quinlan's earlier introduction about diagnostic observations.
Thank you very much. Thank you, Edward, for the introduction. Edward Cotter. As usual with this topic, I get a list of things from Peter Cowan that I might consider talking about. So today we're going to kind of cover in a whistle-stop tour and touch on certainly 4 and hopefully 5 of these topics. This is a wonderful interview with Van Haywood. It appeared some time ago in the Journal of the Irish Dental Association, and it was a series of questions put to Dr. Haywood by our editor at the time, and he answered those questions in his own inimitable style, and it's summarised extremely well in our journal.
It's best if you use that, and then if you use the mouse to highlight it, because the red won't show up.
It's not advancing anyway. So here's a girl on the top of the screen who's going to her DEBS, which is obviously a very important event in the life of an 18-year-old in Ireland. And she's not happy with her smile and a little bit of tooth whitening with at-home delivery. And she goes to the DEBS and dances the night away until her glass slipper falls off and she has to rush home. And basically, Dr. Haywood is saying 10% carbamide peroxide is the safest and it's the most effective. So why would we use anything else? Increasing the strength of the peroxide gives the risk of greater sensitivity. So again, that previous girl, 10% carbamide peroxide for about 8 or 9 nights allowed her to go to the ball and be happy. Gingival irritation, if it happens, is usually due to the biotype of the gingiva, and if we have a thin biotype, we're more likely to get irritation of the soft tissues than not. And similarly, if it's got sort of exaggerated papillary style, similarly. Resorption, we tend to see in non-vital teeth if there has been a history of trauma, if there's been a history of heat application to the tooth, and again, we tend to get away from applying heat now to tooth whitening procedures. And if we haven't sealed, the GP and our endodontic colleague sitting up at the back of the room who's going to talk to you later will be delighted to tell you that you must seal off the GP. And again, similarly, the higher concentration of peroxide that you're using on the tooth or within the tooth, the higher the risk. So again, get away from using the high concentrations. Again, if you do get hypersensitivity, again, in the same journal of the Irish Dental Association is an overview by Denise McCarthy from the Dublin Dental School. And again, it's an excellent review of the problem, what causes hypersensitivity, and again, treatment strategies for hypersensitivity. And the simplest one, I think, if you have a patient who has tooth whitening trays that they're wearing on a regular basis, is just to get them to dispense some of the any essentially toothpaste that is designed for hypersensitivity. And some of the gel ones are particularly good because they flow nicely through the tray. So 1 night of tooth whitening, 1 night of Sensodyne F, for instance, would be one that has a nice capacity. Here's a girl who's unhappy with her smile, coming up to her 21st birthday, daughter of a very good friend of mine, and we're going to look at this girl from 2 aspects. She's going to cover a little bit on the tooth whitening and lead into the part on veneers. And when you're looking at this, if she presents to you, you know, what are the features or characteristics of her smile that you think she doesn't like? She doesn't like the white spots, yeah, and she feels she doesn't show enough tooth structure. So again, a little bit of tooth whitening, and again, we haven't eliminated the problem with the tooth whitening, but you can see we have a brighter background on the colour. The base colour of the tooth has gone from maybe a B3 to maybe a B1.5. Okay, and again, in terms of us doing, and I'm kind of giving the story away here, in terms of us doing porcelain veneers, that obviously gives us a far superior. So here's a little, and again, I'm sure earlier we were talking about diagnostic workups and things. Here's a cheap and cheerful diagnostic workup. In fact, if you look really carefully, you can see my thumbprint on the central incisor. Okay? Well, what am I trying to work out here? I'm trying to work out here what essentially the patient is looking for, because one of the difficulties with this young lady, who, again, very bright girl, was studying physiotherapy in an inferior university out in Stillorgan, she wasn't quite able to articulate what she wanted or what she was unhappy about. So I did this addition to her teeth to help her articulate to me what it was she was looking for. Also, her father happens to be a rather large man, extremely strong, and I wanted to make sure that Daddy knew what we were trying to do as well. And she liked this, and then we went on and did it to the other side, and this then gives me a guide, and it gives the patient a guide, so it's a very good communication between the patient and the dentist. So if we can give her teeth that look like that, she would be very happy, and I know Daddy's going to be very happy as well, and I know he's not going to beat me up. And that's what we did then. We made some porcelain veneers for her, okay? And changed the smile, as you see it on the bottom left-hand side, to what's on the top. And it's a combination of 4 veneers on the anterior teeth and some composite work on the canines and premolars. Because, like all farmers, they're very poor. Okay, so what makes a good porcelain veneer? So that kind of leads from tooth whitening into porcelain veneer. Did you like that, the way I kind of blended into the two of those? Really good, yeah, I thought so too. In my opinion, a porcelain veneer is a ceramic restoration for enamel. Okay, and what you saw on the previous slides was with the composite and with the porcelain veneer, I didn't take away any tooth structure there, did I? Essentially, everything was added. It was added to the facial of the tooth, and it was added to the incisal of the tooth. So again, because her daddy's a big strong man, I was quite categoric in being able to say to him, those veneers are going to be there for a long time, because the ceramic is bonded to the enamel of the tooth. So my concept for a porcelain veneer is always that it's a treatment for the enamel of the tooth. And the more enamel of the tooth you have, the better the outcome is going to be. Where possible, because we don't always have only enamel to bond to. Sometimes we have to bond to dentine. Now, if our eminent dental material scientist, Gary Fleming, was standing here for you, he tells you that all bonding to dentine ultimately fails due to hydrolysis. So again, if you're planning a veneer and you have 50% porcelain, 50% enamel and 50% dentine in the tooth preparation, are you going to make a veneer? If you have 30% enamel and 70% dentine, are you going to make a veneer? So here's a young girl, 13 years of age, conoid lateral incisors. Again, you probably saw something like this from Dr. Quillen this morning, a little diagnostic workup, very simple, cut up the cast, move the teeth, then show to the orthodontist and go, dear orthodontist, can you please do this for me? Or, dear orthodontist, this is what I want, depending on your relationship with the orthodontist. And again, where would you like to have the conoid lateral incisors? Do you think I'm going to be able to make a nice porcelain veneer for this patient, or these two patients as you see them here? And the answer to that question is yes. Why? Because in asking the orthodontist where to put the tooth, I've asked them that I would like 2/3 of the space on the mesial and 1/3 of the space on the distal. Why? Because that puts the zenith of the soft tissue in the right place, where we want it. Think of a normal lateral incisor. In your mind, draw a lateral incisor on that conoid lateral incisor at the moment, and you'll see that again, and if Dr. Cotter had asked you to set up a lateral incisor for one of those magnificent complete dentures that he was showing you earlier, how would you set the lateral incisor? Little tilt to the distal, little tilt to the palatal, gingival contour height, 2/3 the way back. So this puts the gingival zenith in the correct position. I also want them to put the gingival margin in the correct position, incisal-cervically. Okay? And I like to have the tooth slightly palatal because a porcelain veneer is a treatment for enamel. So when I do the tooth preparation, it's a different tooth on the far side of the screen, and it's etched. Look at the small amount of dentine that's exposed in that tooth preparation. Why? Because the orthodontist has left it slightly palatally, and I'm a lazy prosthodontist. I don't like having to work hard cutting teeth, so all I do is put a finish line down there. And little or no enamel is removed. So orthodontists can help us a lot, okay? And here's the final treatment. This is the girl at, believe it or not, 14 years of age. I know we can have a discussion about that, and don't be going, okay? And here's the tooth preparation guidelines that I would use, okay? 0.3 is probably about what we want to take off. 0.5, you're getting in to removing all the enamel in the cervical aspect of the tooth. Go back to your dental anatomy and think of how much enamel is present at the cemento-enamel junction. It tapers out to almost zero. If you're going to make the veneer fit, it can be supragingival. And I'll show you the reason for that in the next segment of this discussion. We want smooth, sharp and margins in enamel. Okay? We want a smooth preparation with no sharp corners so that our laboratory colleagues can make a veneer that's going to sit comfortably and fit on the tooth. We like to have it seating well, so it's nice to have an overlap so you know when you have it seated on the tooth preparation, a positive seating. And then you can think about what you want to do with the proximal margins and the contact points, and whether you want to bring it to the contact point or whether you want to bring it through the contact point, and that depends on what you're trying to do in terms of changing the appearance or wrapping it around or not wrapping it around the tooth. But enamel is precious, and the more enamel you have, the better. So here's these same two veneers 13 years later. Why are they still there? And more importantly, where's the ceramic tooth junction? And you can just about see it after 13 years. Why? Because it's on enamel. Because in doing the tooth preparation, I kept the enamel there. And here they are 17 years later. And they're still there. These slides are 4 years old now. They're still there 21 years later. So it's about technique and it's about enamel. Enamel, enamel, okay? Smooth enamel. Porcelain veneer preparations in 2 words. Smooth enamel. Gee, and why did you spend 20 minutes talking about that, Jerry, if it's only 2 words? Okay, the second most important aspect is if you've done a decent tooth preparation, then you better stick the thing properly to the tooth, okay? So again, now we're going to talk about your bonding technique, because you can really mess it up with your porcelain veneer bonding technique, okay? So there are some tooth considerations. The tooth must be isolated. Again, do you put a cord in or not? I tend to do. Why? Because it keeps the... Edward, could you fix my denture for a sec? And then I could maybe say crevicular. Crevicular fluid. It keeps the crevicular fluid from getting close to the margin, okay? They need to be clean, so that's pumice in water, flour of pumice in water, and then you etch. And again, interesting to look at the center slide. Look at the center slide, the etched tooth. How much enamel do you see there? How much dentine do you see there? It's all enamel, thank you very much, okay? Yeah, exactly. And then we bond, and then we seat, okay? And here is the important word, submargination. What is the polymerization shrinkage of the average resin-luting cement? Hands up for 5%. Hands up for 7%. Hands up for 10%. Hands up for 15%. Hands up for 17%. Hands up for 20%. Hands up for 2%. Hands up for 1%. I'm sorry, Ed, they're all asleep, other than you and that lady at the back, and one person over there, because nobody put their hand up for anything. Okay, so I'm going to throw that back at you and say, you all probably don't know what the polymerization shrinkage of resin-luting agents is. Hands up for people who use resin-luting agents here. Okay, so you guys need to go home and do your homework, okay? Except Edward, he had the answer. It's between 17 and 20%. Now that in terms of dentistry, is like huge. So how do you control 20% of a volumetric shrinkage in your resin-luting agent? Sorry? Can't incrementally cement something, can you? No. But that's how we normally do it. That's how we, can I just finish the point? In a posterior composite, that's how we normally do it. Incremental technique. What's the polymerization shrinkage of a restorative composite? About 2 to 5%. And yet, here we are with something, the 2 to 5% incrementally building it up in 2 millimeter layers so we don't get any shrinkage. And here's something with 20%, and you really don't give it any consideration at all. Why did those margins look good after 17 years? Because in bonding them to the tooth, I controlled the polymerization shrinkage. How? Good question. Fortunately, I put the slides in here to answer that question. Is that okay? Okay, so it's how you handle the excess luting material, okay? So what do? Load the veneer, seat it. And when you seat the veneer, some of the resin will come out from under the margin. You wipe that away. You reseat it, give it another little push, and what will happen? Some more will come out, okay? And you wipe that away, and you reseat it again, and what will happen? Another little bit will come out. I leave that there. And then I cure it. So I have a positive piece coming out from under the margin, okay? Little layer, small little layer. Small amount of excess. And then the most important thing is you're going to use the light to help you. Who takes responsibility for the light here? The dentist or the nurse? And what instructions have you given the nurse? Yeah, it's always the nurse's fault, isn't it? And what instructions have you given the nurse in positioning the light? And the next question before I show you the slide is, where are you going to put the light first? Well, I'll show you what I do, and then you can decide whether I'm any good or not. Because what we're trying to do is control and manage that 17 to 20% of polymerization shrinkage. So here's those 2 veneers that we showed the cleaning up, okay? And you can see the excess cement, and you can see I'm wiping it off. And the one on the second, on the far side of the slide, is pretty much where I leave it before I apply the light, okay? So I remove a good bit, but you can see there's a small amount of material there. And where do I put the light first? Right there. Why? Because the only thing this patient is concerned about is that this veneer looks nice in 5 years' time, 10 years' time, 15 years' time, and 17 years' time. So you want that to be properly sealed so that the cement doesn't get drawn in under the margin and leave a little line which will pick up every cup of coffee that you ever drink and every glass of red wine if you have that sin, okay? And that is the term submargination. So by applying the light first here, I seal that perfectly. And then I put it on the palatal, and then I put it into the body, and then I clean it up, okay? And that's all predicated on the margin fitting well. The margin fitting well is predicated on you making a decent tooth preparation of having smooth enamel, because if you don't, the laboratory can't make it fit properly. And then we finish it, okay? And again, you just work your way through them, and PJ made this slide for me because I'm not very good with PowerPoint. And again, there's a veneer. Is that going to look well in 10 years' time? Absolutely. Okay, why? Because we've applied all the things that we need. Okay, we're not going into that one in detail because it doesn't add to the discussion, okay? And I have 5 minutes and 39 seconds left to get through 2 more topics. Okay, let's talk a bit about posts and cores. The strength of an endodontically treated tooth is directly related to the bulk of the remaining dentine. Okay, so you keep the tooth structure because, again, if enamel is precious in porcelain veneers, in posts and cores, dentine and enamel is precious. And the more dentine you have of the crown of the tooth for your restoration, the more successful it's going to be, full stop. And now we can skip this section and go on to the next one. Because if you understand that, then that's all you need to know. Okay, the 4 factors in terms of the success of a post and core are the width of it, that we don't over-widen it, that the length of it is equivalent to the length of the crown, okay, and that we have a ferrule, which is the crown engaging dentin. A dentin core beyond your metal core, your enamel core, or your composite core, or whatever material it is you're using, okay? And that's all predicated on the conservation of tooth structure. Here are the recommended average diameters of a post preparation measured 5 millimeters from the apex of the tooth. And that's the other mistake we make, because when we're doing a post preparation, we're looking at the pulp chamber. And we're looking at this thin instrument, whatever instrument we use, and it seems to be swimming around in a big space, okay? But the real issue is how wide are we prepping it high up there where we can see without the aid of a radiograph, 5 millimeters from the apex. Mandibular incisor 0.6 millimeters, maxillary central incisor, canine and the upper molar palatal root 1 millimeter. Okay, how wide is a yellow parapost? How wide? 1.4. Look at the box again, okay? Again, most popular post we use is the yellow one, or the blue one, which is after it, okay? A number 3 piezo reamer, 0.9. A yellow parapost is 1 millimeter in diameter. The blue is the next one up, I think, which is 1.12. And a round bar, a number 2 round bar is 1 millimeter. So again, think of that in terms of what you're sticking into a tooth to make a post preparation. Lloyd and Pallick, 5 millimeters from the apex, because that's where the tooth is at its narrowest. And whether you decide to leave a millimeter or whether you decide to leave a third, you can decide yourself, okay? But in that area, you've got to be careful that you're not over-widening the tooth preparation, because that's where the weak point comes and that's where the fracture starts. So again, little reminder. You've got, think of the think of the Gates Glidden box, you know, all those little drawers. The yellow is second one from the top, I think, isn't it? Yeah, and then there's a lot of them down there below it. And some of these newer ones, here's the Taper Lux one, the smallest one is the blue, 1.14 millimeters. So already you're straying into something that's going to be close to being too wide in most teeth. And that's the smallest one available. I have used this picture in this lecture every year for the past 25 years. Again, I told you earlier, I'm lazy, okay? But here are 2 upper first premolars. One I found in the dental hospital one Tuesday morning, and the other I found back in my practice. One of my colleagues had taken it out for orthodontic reasons. And that is a number 2 piezo reamer, 5 millimeters, 4 millimeters from the apex. And every time I put that slide up, it frightens me. Okay? And I hope it frightens you. Because that's where we need to judge the width of our tooth preparation. It even looks worse on the proximal surface. Dr. Glennon made me put this slide in. Okay, so the length, as long as possible, but we want it to be equal to the length of the crown. At least equal to the length of the crown. But our endodontic colleagues want us nowadays to leave 5 millimeters of residual GP to ensure seal in that area. Kvist, who did the study, showed that most leak, if you have 3 millimeters, almost no leakage at 4 millimeters. That's why we get the 5 millimeter guidance. Here's the ferrule. Here are 3 post preparations. Look at the dentine that's left apical to the core. And it's the crown embracing that piece of dentine that binds and holds the tooth together. The classic analogy is, you remember your grandfather's walking stick, the wooden walking stick and at the bottom of the wooden walking stick there was a little brass ring. Why was that there? To hold the wooden walking stick together, okay? The crown holds this whole assembly together, okay? And look at this statement. A post preparation with a 2mm ferrule does not weaken the tooth. Isn't that fantastic to know as a restorative dentist? 360 degrees, 2mm height, doesn't weaken the tooth. And a post does not strengthen the tooth, but when the ferrule is 2mm, it does not weaken the tooth. A fantastic piece of information to know when you go to do your post preparation. So don't over widen it. So take that Parapost box and throw everything on the bottom of the box in the bin. Or give it to your kids to play, I don't know, whatever. The length equal to the length of the crown, okay, but leave and keep our endodontic colleagues happy. And make sure that you have a ferrule. And again, looking at these two, which of these do you think lasted 2 years? The central or the lateral? Actually, the centrals lasted about 20 years. How long do you think the lateral lasted? Yeah. And Dr. Byrne very kindly has put an implant into that lateral incisor about 2.5 years after it was restored. I'm sorry, I'm over time. I'm just going to finish at this, if that's okay, Dean. Okay. Prefabricated posts and cores, again, if you're cast post and core, or whether you're going to be using a prefabricated system. Again, this study, Journal of Prosthodontics, looked at all the new materials, carbon fiber, ceramic, and the other materials come to me in a moment. Anyway, they looked at the composition of the materials, they looked at the properties of the materials, they looked at the laboratory and clinical test results. And basically, when they lump them all together, they have good physical and mechanical properties, similar to tooth. Post-loosening is a big problem with them, but look at the same statement. An adequate ferrule prevents root fracture. So if you are using these new materials, the classic factors in post and core success of width, length, ferrule, and the conservation of tooth structure still apply. So please, make a post to fit the available space, not a space to fit whatever happens to be left over in the drawer on Tuesday morning when you go to do it. Okay, and this is Morgano, who has done the most work and publication on this. Okay, thank you very much for your attention.
I think that was brilliant and has really got us thinking, and a lot of take-home messages. We're going to have a coffee break now, and then Dr. Byrne and Dr. Glennon will be doing periodontal and endodontic considerations. So if I could get you back, hopefully, so you'll be able to see the rugby match and everything in, say, 15 minutes. I'll be out ringing the bell. Thank you very much.
And maybe a little bit of help with your exams. So when this person comes in on Monday morning, they're not scheduled, they're in a lot of pain, getting worse, getting irate, lost sleep. You now have to determine the status of that pulp. It's concealed within a body compartment, you can't examine it directly. So you are depending on indirect information to make a diagnosis. You depend on information from the patient, special tests, radiographic interpretation to reach a diagnosis. So we need to have a series of questions. Everybody has their own format, but the essence is you're really trying to find as much information about the character of this pain, the intensity, frequency, localization. And these questions are helping you to form a tentative diagnosis. Information you've gleaned here may also determine special tests that you're going to do, which will either confirm or refute the diagnosis. So what makes it worse? Oh, coffee kills. Okay, you're going to test that with warm water. And this is what you're looking for during this series of questions. In fact, you can get useful diagnostic information from the patient's descriptors. So pain can be provoked by a hot or cold stimulus. Produces sharp pain. That's our A delta fibers. Stimulus is removed, the pain goes in a matter of seconds, or it may last for hours. That changes in character. That might be deep, it might be throbbing. It can go on a little bit longer. Patient says, oh, it was so bad, it's lasting for ages. But you know, cold water eases it. That actually tells you it's a marker for excessive and irreversible inflammation. As the inflammation spreads beyond the pulp chamber and the canal into the periradicular tissues, the symptoms may change, the character changes, and you talk about a dull, a drawing, aching sort of feeling. Patient may be talking now that it's sort of bite on the tooth, it's tender to palpate, and it's tender to percussion. At this stage, temperature probably will not provoke the pain, so you need to be aware of that. We go into our special investigations, and as I've said, these are governed by what we have heard in the history. Use more than one test because none of our tests are 100% accurate. You need to establish in your questioning if the pain comes on immediately or it takes a little bit of time to build up. You test remote from the tooth that you're interested in, and what's really important is that you explain the test, that you're using a suitable vocabulary. Even within this room, if I say, to me, the word sensitive means cold air in, that's sharp. It's a bit like the Sensodyne ad on television. To some people, and some of you will be included in this, sensitive means it's a bit sore when I touch it. That's pain that's mediated through the periradicular fibres. So it's really important that you and the patient are talking about the same thing. When you're testing, take the time to put a single hole in a rubber dam and put it through the contacts. Cover the entire clinical crown with the stimulus, and using simple things like cold water in a syringe or hot water in a syringe avoids excessive rise in temperature. We actually let the hot water tap run, and in good old-fashioned tradition, we let it get as hot as it can, and then I test it like you do a baby's bottle. If it burns me, it's too hot. What does our tenderness to percussion mean? It's telling us that there's inflammation in the periapical tissues, that's all. Could be high restoration, could be sinusitis, orthodontic treatment would be obvious, periodontal disease, lateral periapsis, parafunction. It tells us absolutely nothing about the health of the pulp. Tenderness to palpation, that's really where the inflammation in the periodontal ligament has spread to involve the periosteum around the jaws and around the tooth. So it can be useful in the maxillar premolar area particularly. The electric pulp tester. This uses electrical current to excite a response from nerve tissue within the pulp. So it's actually stimulating your A delta fibres, the short and sharp fibres. Need to be aware that there isn't a consistent threshold for healthy teeth. So years ago we used to have a sticker in the dental hospital that said incisors respond 0 to 30, canines 30 to 40. That's rubbish. This is a battery device. Your battery may be flatter than it was the last time you tested. And it isn't a quantitative measurement of health. So if it responded at 50 last week and it's 30 this week, it doesn't mean it's more painful this week. It doesn't mean it's more healthy. It is a response. It's determining a nerve supply. It's not telling you anything about a vascular supply. And we can be tricked with false positives. You might have liquefactive necrosis in a tooth, giving you a response from the C fibres, and you may have a multi-rooted tooth where some canals are vital and some are not. So, I don't know whether you can read this, but all this text is so I can explain. Patrick went to his dentist end of November, and he complaining of spontaneous shooting pain in the lower left. It was present about 2 weeks. When his dentist examined him, the lower left 7 and the lower left 6 were sensitive to cold air. His examination of the radiators led him to believe that there may be caries mesially, so he replaced the filling, and his note said it was deep but it wasn't exposed. The following day, Patrick rang back, and he said, there's no improvement. It's still sensitive to hot and cold when I'm eating and drinking. The dentist saw him, checked the occlusion, and something in the history just alerted him. He said, I'm just going to take the filling out, I'm going to put a sedative dressing in. All good standard of care. A week later, Patrick came back and he said, no change. I got a temporary improvement for the first 2 days, but I'm really back now where I was. And the dentist diagnosed irreversible pulpitis and commenced root canal treatment at that 6. He instrumented the 3 canals and brought them up to a pro-taper F2. So he had well prepared. You would not expect to have further discomfort from that tooth. It doesn't happen. It does. A week later, patient comes back, still complaining of pain. Actually, if anything, it's getting worse. The lower left 6 was tended to percussion, and no other tooth was tended to percussion in that quadrant. He re-instrumented the canals, and actually he found a fourth canal. Unfortunately, he fractured a file, and then it's sent to me. There's a huge emotional component in it now, and that can cloud the picture. Somebody has taken huge care all along in minding this patient, and this has happened. You've got to go back to the basics, take the history, look at the hints from the patient. Patient came in, he's quite stressed, he now hears he's got a broken instrument, and that really clouds their view. But he's telling me he's spontaneous pain. It's coming on, I'm watching television, it's there, I could be 20 minutes with it, and if I have a cup of coffee, oh my goodness, it's hell. It's coming on in waves, and he's now aware of a sensation of pressure. When you examine him, the lower left 6 is slightly tended to percussion relative to the adjacent teeth, but he's had 4 interventions at this site in 3 weeks. No other tenderness could be elicited with the tooth sleuth at the lower left 6 or the lower left 7. There's a 6mm pocket on the 6, there's a 7mm pocket on the 7. What do? I actually follow the patient's instructions. You've got to try and reproduce the patient's pain. Rubber dam isolation, hot water, put it on the 6, no pain. Put it on the 7, absolute agony. Put it on the 8, nothing. First stage root canal treatment on the 7, which is irreversible pulpitis. Pain is resolved within 24 hours. We need to remember, reversibly inflamed pulps very often don't show radiographic change. You might be lucky and see a widened periodontal ligament space. And not every necrotic pulp will have a periradicular radiolucency. I'm slightly hesitant in putting up this chart because actually in real life the distinction between reversible and irreversible pulpitis, there isn't a clear cutoff, but there are good useful pointers in it. Along with that, Dr. Quinlan gave a really good definition of differential diagnosis, and you have to consider that endodontic and periodontal conditions can coexist with non-odontogenic phenomena. So in your differential diagnosis, you may have to consider some of these other entities, and this list isn't exhaustive. So tip 1, diagnosis, careful history, special tests to reproduce the patient's pain. If you can't come up with a diagnosis, don't treat. See them in 24 hours. It may localize in that 24 hours or refer. If we're going to do root canal treatment, we do our access cavity to allow us access all parts of the root canal system and that we can instrument and fill the canals. We all need to have a working knowledge of how many roots are in a tooth, how many canals to be expected, how many in a lower incisor, etc. These are all standard from a text. They're ideal access cavities. But actually, in real life, many clinical situations, crown, dystrophic calcification, occlusal trauma, large restorations, they'll alter the original anatomy, and we very rarely go into a virgin tooth unless it's trauma. In some of these real-life teeth, ideal access cavities may actually under-prepare or actually over-prepare the teeth, so just be aware. If we look at some of these access cavities, just remember in our maxillary incisor, we need to extend it as far incisally as we can. Don't go across onto the buccal surface, but really do bring it up towards the incisal edge. These cingulum-based access cavities end up creating file restrictions. If you use rotary instruments in this environment, they'll break. You've got to be careful with the cingulum approach because if you extend too far, you'll weaken the labial surface here. You may even perforate. In premolars, the pulp is kind of a shrunk-down version of the shape of the clinical crown. The access cavity in an upper premolar really should be broad buccopalatally, narrow mesiodistally. If we look at these photographs, look at the colour here. As we develop the access, look at the colour here. This dentinal map, this dark shading, that's what you need to look for. Your upper molar, your 6s, there's nearly always an MB2. Look at the colour of the wall, look at the floor, look at this dentinal map. Where do you expect to find the orifices? Your mesiobuccal is most times much further out than you realise, and that distobuccal, watch where it's positioned. If you're looking for the mesiobuccal too, consider drawing a line from that palatal to the MB1 and drop a perpendicular from the DB. It might help. A word of caution. Look at the mesiodistal width in the contact area. Look at the mesiodistal width at the cervical level. If you don't recognize that difference and put an access cavity in this direction, you're going to overcut this tooth and weaken it in a very vulnerable, important cervical area. So your access does need to be tapered. We talked about the dentinal map. I've been asked to locate the third canal in this tooth. And if we look, this is the same colour as the wall. We're looking at the roof of the pulp chamber here. You need to use your endo-Z burr and extend it, and here we start to see the dentinal map on the floor. We found our third canal. Lower incisors, previous cingulum based access. We need to involve the incisal edge. And in fact, if the tooth has a lot of faceting, we may need to extend it out onto the buccal surface. In doing so, we have a better chance of locating that second lingual canal. Again, premolars, access cavity broad, buccolingually, narrow mesiodistally. Word of caution with lower premolars, we need to be aware of this crown root angulation. So if we have a look at this here, we can see there's quite an angulation here. If you direct your access cavities between the two cusps, you're actually not going to get direct line access to the apex. And in fact, in doing so, you may create a perforation, you may fail to locate the canals, you're going to weaken the tooth and your misidentification of your canals. In that situation, that buccal, that access needs to be brought out onto the buccal. Don't be afraid of it. We've got lovely posterior composites. You can do that. Lower molars, have a look at the floor again. Dentinal map's not so easy to see here, but across between the two mesial orifices it is. Draw a mental mesiodistal line. Mesial canals are lying a line perpendicular to that and equidistant. This symmetry applies to all teeth except maxillary molars. If it's a lower molar and there are only two canals in it, the two will lie on this mesiodistal line. Think laterally. This is courtesy of one of our undergraduate students who commenced root canal treatment on the lower lateral incisor. Look at the width here. He couldn't actually reach with his high speed, so he's put the access on the buccal. That's fine. So, if you're going to do endodontics, you need to have a working knowledge of anatomy. Be aware of the number of roots, how many canals, where you expect to find the orifices. Have a look out for the dentinal map. Two lower first molars. Would we perceive one of these was easier to treat than the other? Would we alter our technique? If we look at the working lengths on these two teeth, the one on the left, my left, we've got 18 millimeters. So the chamber height, or from the cusp tip to the orifice, is about 9 millimeters. In this tooth, we're probably instrumenting, using the file, about 9 millimeters of the file. If you go back to your undergrad days and remember, the blade is about 16 millimeters long on these files. In this tooth here, if we take away 9 millimeters, we're going to be instrumenting 14 millimeters of that file. That's a lot of contact, that's a lot of dentine being worked. You have very poor tactile feedback with that, and it creates ledges and creates a lot of dentine debris. So we coronally prepare to try and eliminate that problem. And that basically means that we're removing the bulk of the material coronally before we prepare apically. It allows better penetration of the irrigant and deeper penetration of the irrigant. You also get better tactile feedback in your instruments when you do that. Cliff Ruddle would say that there is less pain because there's less contaminated material pushed through the apex, and your apex locator readings can be much more reliable. If you look at the research, when instrumentation is done apically before coronal, i.e. what we used to call original step back, there were more procedural errors because we couldn't remove the dentine debris. So we start coronally, we look at this cervical dentine. If you don't remove this might be the reason you haven't found your MB2 in your upper molar. If you continue to work this file here, it's catching here, it's catching here, here, and down here. You have no feedback as to what you're actually doing. So without extending that into your canal, we're still working in the chamber, removing this cervical ledge. And you can see when we instrument here in this last diagram, we have a much better approach to that apical third. Removed your cervical ledge, we need to prepare coronally. So we're introducing successively larger files a shorter distance into the canal. And you're working this area here. You're preparing a little path. So you can subsequently use rotary instruments to prepare coronally. I'm using Gates Glidden 432 for a specific reason. I think it's very difficult to be disciplined and not advance apically with your Gates Glidden. These should only be used on the outstroke. You should not be advancing them apically. The ProTaper SX, a very nice instrument that does very similar. Most times you lose a little bit of both. But if we look, we've removed all of that area there now. When we go to prepare apically, if we look at the amount of contact with our files, it's much more reduced. So here's the improved tactile feedback. We're going to work that 10, and then we're going to prepare that apical third. We've established the working length, so 15, 20, 25, 30. Okay. If you use rotary instrumentation, you're probably going to introduce it at this point. So, we've prepared coronally with our Gates Glidden or our SX. We've prepared apically, possibly with our hand files. We need to join the apical preparation up to the corona preparation. That's what creates taper. If you're using a rotary system, that's already inbuilt in the system that you're using. We need to consider a patency file. That's a very small file, passed about 0.5 millimeter beyond your working length. It allows you to increase your working length if you need to, and you should be using the smallest file possible. This research from Kishkula, Bavala and Paula Ng and the Eastman, where they reviewed their success rates over very considerable numbers of teeth, they felt that achievement of patency at the canal terminus significantly improved their periapical healing. So, when you're preparing, it's not all about the rotary system that you have in your practice, it's the principles of how you do the job that's terribly important. So, these radiographs are quite old, 1998, and these 4 incisors were probably treated by the same person. Why are 2 of them giving trouble? I retreated 2 of them. In my retrospectoscope, I'd say I over-prepared the right 2. But actually, we're still doing fine, and we're still doing fine. But so are the other 2 teeth. Why did they work? It's a matter of continuous debate whether a smaller apical preparation allows sufficient antimicrobial action to take place. In this research work, this paper from Paul and Kish, in their discussion, they suggested that apical preparation size 30, using a millimeter step back in your hand files, or if you're using a nickel titanium system that has an 0.6 taper, that should allow adequate exchange of irrigants so that we can get antimicrobial action going on. If we look at this work from Ove Peters, so he did these micro CTs, pre-op, post-op, superimposed them, and if you look as we rotate through the images, the amount of show-through of green, that translates to areas that weren't touched as they were instrumenting. And when they analyze it, almost 50% of the surfaces remain untouched, irrespective of whether it is hand or rotary. We look at these cleared specimens. We know that surfaces remain untouched. We know that there are areas that are inaccessible that we'll never get to. These lateral communications we will never get to. And we know that there is an invasion of the dentinal tubules in cases that have apical periodontitis. So we need to look beyond the mechanical side of what we're doing when we do root canal treatment. There's a lot more focus on our irrigation. With that, we need to critically look at the amount of contact time, the amount of exposure time we have, how long is the irrigant in the canal. How do we deliver it? Very hard to know how much irrigant you should use, how long should it be there. This reference from Holtzman is the only one that I could get somebody to come off the fence and say 30 minutes in single rooted teeth. If you move your size 8 file up and down between each file size, you will improve the irrigant penetration into the canal. If you add ultrasonics, you actually get a significant reduction in bacteria. But you need to take into consideration how big your prep is there a curvature, because they all affect the fluid dynamics. If you're using sodium hypochlorite, we need to be really careful. We need to avoid sodium hypochlorite incident where we've extruded the material, because that's quite significant. Lower lock syringes and side vents. For all that, sodium hypochlorite is still the irrigant of choice because it's the only irrigant that has the capacity to dissolve tissue, and that sets it apart from everything else. It's most effective against biofilm. It has a broad antimicrobial spectrum. If you increase the concentration, you'll increase the tissue dissolution properties, but it doesn't make a difference to the antibacterial effect. Lots of volume because it's quickly inactivated. There's a role for ethylene diamine tetracetic acid. You can use it as a lubricant in the early stages, and only at that point is it used, just for initial negotiation. And you use it then in a liquid form to rinse out at the end of treatment. And it was traditional to use the gel right through your treatment. The problem is it creates deviation in curved canals. This research from the Eastman, interestingly, they found if you rinsed with EDTA followed by sodium hypochlorite, you got an improved outcome in retreatment cases. Matthias Zender is part of a group, Scandinavian group originally, that do a lot of research on fluid dynamics and antimicrobial properties of solutions and how we keep the canals as clean as we can. And that was a regime that they had recommended. 1% sodium hypochlorite, keep the canals flushed with it all the time. Don't alternate with EDTA. When you have finished, rinse with EDTA for 3 minutes. That's when all your preparation is done. And then he used this ultrasonic, this passive ultrasonic irrigation. So 20-second pulses, fill the canal with sodium hypochlorite, use ultrasonics, rinse it out, do it again, repeat it another time. And then he let it sit there for 20 minutes. Obviously not practice-paced. He was doing a lot of one-visit endodontics, and they were using resin sealers. So actually at this point, he would then rinse out with EDTA before they obturated. If you weren't using a resin sealer, then it is, you would leave sodium hypochlorite as the last rinse. I spoiled this slide. But if you take nothing else home, just remember, we never irrigate enough, we overestimate the time we've taken, and we never irrigate too much. It's probably the single most important factor to improve your outcome in endodontic treatment. Last point. If we look at these radiographs, there's 9 months apart, there's huge healing if you look from one to the other. What do? We completely instrumented the canal in the first visit, we dressed it with calcium hydroxide, we put reinforced zinc oxide as temporary material, and we got healing. So why do we obturate? We actually obturate because it's taken endodontists a long time to recognize that as wonderful as we think we might be, we do not get the canals 100% clean. There are bacteria left behind. So you need to entomb them, that they are deprived of nutrients and that they don't actually flourish. So you need your root filling to actually prevent new infection, entomb, deny nutrients, and space to multiply. So we do need to obturate. What techniques? Within the literature, no single approach can actually equivocally boast superior evidence of healing success. And in reality, for most of us, it's a case of, I like the feel of that, I like something new, it's easy to use. We do agree we need to maximize the volume of GP, minimize the volume of sealer. So be careful about the single cone technique. We do agree we need to use heat because softened GP is better adapted and anatomical irregularities are better filled. With that responsibility, if we consider why we're obturating the canal, we also need to talk about coronal seal. GP and sealer leak and should be protected from the oral environment. There are accessory canals in the floor of the pulp chamber. So don't put in a wad of cotton wool and put a B&T on top of it. Put your B&T directly on top of the GP, because they may not come back next week. If you have time, put in an amalgam or put in a glass ionomer, a resin-modified glass ionomer. Make sure it's at least 3 millimeters thick. And that goes for your temporary restoration. If we look at this radiograph, a treated case, there's a year almost between, there is a year between the radiographs. The amalgam is extended into the GP. There's at least 3 millimeters between that GP and the oral environment, and that's what you need to do if you're not going to crown it. So, my 5th tip, the root filling extends from the occlusal surface to the apex. Use heat if you possibly can, and understand coronal seal. Thank you very much for your time.
Thanks very much, Dr. Glennon. really logical and brilliant lecture. This is like the rugby match this afternoon. Joanna and PJ are the impact subs coming on. 40 minutes to go. Ireland are down, and the star comes on. PJ Byrne, President of the Irish Dental Association, past Dean of the faculty here. He's going to make 5 points. He's going to score 5 converted tries, and Ireland are going to come out winners. So PJ is going to be talking about periodontics.
If it falls down my leg, you know what's happened. Very good. That's good. Thanks, Ed. You're all very welcome, and thank you all for staying here. Obviously, not too many rugby fans in the audience. They've all left already. But you'll be glad to hear I'm not going to tog out in front of you or anything like that. And whether I'm Sexton or whoever it is, we'll see if I can hopefully not score an own goal. Peter Cowan, the CEO, has just sent me a text, which is why I've got my mobile phone in my hand, just to remind everybody, please, to fill out their feedback sheets at the end of the session. And please leave them so that we can collect them. And some poor soul, probably Eddie Cotter, is going to have to grab them and take them back to the office. So we'll get rid of the mobile phone at this stage. So, last of the day. Let's not make it the sleeping slot, shall we? We'll try and keep moving fairly quickly. You've had a great day today. You've had a huge amount thrown at you. Really, we're telling you what you need to know as opposed to trying to teach you what you need to know. We're giving you the headlines of what you need to look at. And as we come to the end, I'm going to talk about periodontics, a whistle-stop tour of periodontics, but it's very exam focused. And when you look at the syllabus for the MFD or the diploma, you'll see that we have tailored this course today to be specifically exam focused. This is to remind me, this is in Khartoum, so a welcome to all of those who are joining us on the various links. Massa al-Khair to all of you at this stage of the day in the Middle East, and I hope you're all well and lovely to speak to you. So periodontal disease is very common, we know that, and we know that mild to moderate forms affect a significant number of adults, and the severe form affects obviously a lesser number. And we know that periodontal disease has an even higher prevalence in developing countries. Dental biofilm is a contributor to the etiology of most periodontal diseases. And we accept that the immunological and inflammatory responses to this biofilm are manifested by the signs and symptoms that we know to be periodontal disease. And the outcome of these interactions is modulated by risk factors or modifiers, which are either inherent, like genetic factors, or acquired, like environmental factors. And these significantly affect the initiation and progression of the different periodontal disease types that we see. Currently, periodontal diseases are classified based on clinical disease traits and using radiographs and largely clinical examination. Today's classification looks something like this, very different from the classifications of old. I don't have the time, unfortunately, to dwell on it. But we're advancing in terms of things like genomics, molecular biology, and personalized medicine, and these new techniques may result in new guidelines for unambiguous disease definition and diagnosis into the future. And more recent studies have implied relationships, as we all know, between periodontal diseases and systemic conditions. Note I said periodontal diseases. Chronic diseases worldwide are a growing burden to the health services. And periodontal disease is one of those very important diseases which is contributing. And we know that it does vary a lot in different countries. In addition to things like socioeconomic status, periodontal health status is related to several factors. Modifiable risk factors such as tobacco use, excessive alcohol, poor diet, nutrition, obesity, psychological stress, and insufficient personal oral hygiene. And these are all important factors. And these principal risk factors for periodontal disease are also shared by other chronic diseases. Periodontitis begins with a microbial infection, followed by a host-mediated destruction of the soft tissues, caused by hyperactivated or primed leukocytes, and the generation of things like cytokines, eicosanoids, and matrix metalloproteinases. Imagine saying that at 4 o'clock in the afternoon. That cause the clinically significant connective tissue and bone destruction that we know occurs in periodontal disease. Bacterial accumulations on the teeth are essential to the initiation and progression of periodontitis, and the research of the 1970s in terms of plaque certainly demonstrated that very clearly. But we accept that dental plaque microorganisms existing in the form of biofilms are the primary etiological agents. And there's compelling evidence that some subgingival microorganisms are more important than others. However, it's clear that chronic and aggressive forms of periodontitis are not monoinfections and appear to be different from a microbiological perspective. Cells that mediate immunity, such as neutrophils, play a major role in the host defense mechanisms against the various organisms. And if these organisms or biofilms are not disrupted on a regular basis, we get a shift from a largely gram-positive to a largely gram-negative anaerobic bacterial spectrum of activity. And we have all these wonderful bacteria that I know you know how to spell, like Actinobacillus actinomycetum comitans, as Eddie Cotter said earlier, forward, backward, in reverse, and upside down. And we know that these organisms consistently associate with periodontitis. These bacteria activate many of the host immunoinflammatory processes and disrupt host mechanisms involved in bacterial clearance and are considered pathogens in periodontitis. Environmental and genetic factors accelerate the inflammatory processes that we see in periodontitis. Up until more recently, we were largely concerned with bacteria, and we largely ignored viruses in terms of periodontal etiology. But today, there's a lot of interest in particularly 2 viruses that have been looked at: the Epstein-Barr virus, which hopefully we'll all avoid, and CMV, cytomegalovirus. And these viruses are the most commonly researched today, and we'll hear a lot more about them as time goes by. I'm not going to teach you how to do a clinical examination. Paul Quinlan has looked at many aspects of that already. But in terms of periodontal examination specifically, you need to visually inspect the gingiva. We need to look for inflammation. We need to look for changes. We need to carry out a periodontal probing. We need to assess plaque and calculus. We need to look at mobility. And we should chart all of this in a very specific form, which is there and can be reproducible and can be added to and reviewed into the future. It's important to know something like the basic periodontal examination, the BPE. This is the one from the BSP, the British Society of Periodontology. In the States, you have the PSR, and it's similar to the CPITN. Again, time precludes, but we have 0 to 4 and an asterisk, and I'm sure you all know that inside out, back to front, and upside down. This is an example of the BPE score. So you, in each sextant, record a value as appropriate, and it also gives an indication in terms of the type of therapy that's appropriate to carry out in that sextant. When I was an undergraduate student, and you'll probably look at my hair and say that was a hell of a long time ago, but I was always confused about 1 wall, 2 wall and 3 wall defects, osseous defects. So just in case there's any lack of clarity, this is a 1 wall defect. There's 1 wall left, okay? And that's the part to remember, 1 wall left. We have 2 walls left. We have 3 walls left, okay? So that's how it's defined. And then we have our crater. So everybody hopefully is clear on that. Radiographic examination, well, we're becoming more conservative. Very often we take a panaural radiograph as a general screening. We supplement that with bite-wing radiographs, which are absolutely superb in terms of periodontal diagnosis and particularly tracking bone loss over time. Also periapical radiographs, and don't forget things like vertical bite-wings as well. And today, in special circumstances, we have the CBCT, where we can look in this particular case where we have a rather complex issue in the lower right molar region. It's also good to know periodontal disease descriptors. So when an examiner asks you, what type of disease have we got here, it's good to know, have we gingivitis only? Have we mild periodontitis, moderate or severe? And be able to describe that and distinguish between them. So we'll talk briefly now about the periodontal systemic interface. Periodontitis can be a manifestation of many systemic diseases, and in most of these systemic diseases there's either a decreased host resistance to infection or changes in the gingival connective tissue that increases its susceptibility to inflammation-induced breakdown. Although bacteria initiate periodontitis, host-modifying risk factors appear to influence the severity and the extent of the disease. However, determining the role of periodontal infections in non-oral diseases is something which is fraught with difficulty in the literature, although nowadays we know that there are a lot of associations with cardiovascular disease, stroke, and other illnesses, of which unfortunately I don't have really the time to go into. Aggressive periodontitis has a strong genetic component, and it's more prevalent within families, and family aggregation has been adopted as one of the major criteria for the diagnosis of aggressive periodontitis. And it's been well established from the twin studies that you see below that genetic factors may contribute substantially also in the risk of chronic periodontitis. In terms of conclusion with regard to genetic factors could be responsible for the different characteristics that may distinguish chronic periodontitis from aggressive periodontitis. A number of studies to date have indicated that patients with periodontal disease may be at increased risk for adverse medical outcomes, and that's something, of course, which is very important to people's general welfare. So as a result, the concept of identifying risk factors, risk profiling, is something we should engage in with our patients. And whether that's in a structured form like this one, which I've been using for over 20 years now, or you may choose to have it on a yellow post-it, but maybe try and go for something a little bit more formal. It's important you identify those factors for the patient because it also makes sense to the patient. And what does this profiling do? Well, it helps the clinician to help to optimize therapy. It also gives the information to serve as a basis for establishing the treatment plan, and after therapy enable evaluation of treatment outcome. And the data is also useful in terms of monitoring our patients during maintenance and also in the very long term. So, a little brief run through periodontal surgery at this stage. We have two basic techniques, the gingivectomy and the periodontal flap procedure. The periodontal flap procedure has been described over the ages, and you can see the evolution of the various flap techniques from the original Widman flap just around the First World War period, right the way up to modern regenerative procedures of today. And a lot of the work that's done today, periodontal microsurgery, and here's my endodontic colleague in case you don't recognize the masked invader, is basically done under magnification. What are our indications for surgical periodontal treatment? Well, impaired access for scaling and root planing, impaired access for the patient in terms of carrying out plaque control. A lot of what we do is restoratively driven treatment. Maybe where aesthetic improvements are required. Jerry Cleary alluded to that earlier. And a lot of what we do is in terms of implant site preparation, preservation, and modification today. In terms of our gingivectomy, these are questions you could be asked in the exam. What are the applications of a gingivectomy? It has an application in deep suprabony pockets, reshaping abnormal gingival contours, and in gingival enlargement. There are limitations though. We may have a limit to the zone of attached tissue, and we want to try and preserve that. Now, nobody's going to die because of a lack of attached gingiva, but it's an awful lot more comfortable for the patient to carry out maintenance if they have a zone of keratinized tissue. There is, in the gingivectomy, no access to infrabony defects, no access to furcations, and as a result, there are more limited applications. The healing is largely by secondary intention, in other words, granulation, and a periodontal dressing of some description is usually required. In contrast, the periodontal flap procedure, the advantages, well, we generally preserve most of the attached tissue. We have access to infrabony defects. We can look at the morphology of bony defects. These can be visualized. We have access to furcations. We have facilities to carry out recontour of the bone or augmentation. The flap can be repositioned in many different positions, apically, coronally, laterally, etc. So much more widespread applications, and provided the flap is designed correctly, the healing should be by primary intention, so we get primary closure. The modified Widman flap, which is the sort of basic design that very often we use today and have done for some time, essentially incorporates 3 incisions. First of all, we have the first incision, which goes to the crest of the bone. We have the second incision, which effectively goes into the gingival sulcus, and the third incision, either sharp or blunt, is designed to separate that piece of tissue and then allow that to be curetted away. So here is a very, very quick example of that using one of the little Swan Morton micro blades. They look huge on this slide because of the magnification. But here we are with our outline, our second incision then into the gingival sulcus, and remember we're doing the same on the palatal side. And our third incision, be it sharp or blunt, I usually use a Gracie or a similar curette to do that. And then we can elevate our flap. We can choose to elevate our flap minimally, so in other words, not beyond the mucogingival junction, and as a result, the tissue is fixed. Or we can extend that reflection beyond the mucogingival junction if we want to apically or coronally reposition our flap, and then carry out bone modifications as we wish. But in our selection criterion, be it surgical or non-surgical therapy, this should be based on a careful consideration and discussion of the benefits and harm for that particular patient and site with our patients. We've learned that While non-surgical and surgical methods result in similar long-term treatment outcomes, surgical therapy may have advantages in areas which have initially very deep pockets. The surgical technique chosen, however, when we look at the studies in the round, seem to have limited influence on the changes in clinical attachment gain. So it's not quite as important though. What has not changed though is the importance of thorough mechanical debridement and optimum plaque control for successful non-surgical and surgical periodontal therapy. Non-surgical and surgical periodontal interventions ought to be viewed as complementary or discretionary alternatives rather than as opposing types of therapy. Because the great battle in the literature, as we saw in the 80s particularly, was surgical versus non-surgical. That's not the way we should look at it. We need to choose the techniques, be it surgical in one part of the arch, perhaps non-surgical in the other. So, this is an important aspect, that we need to choose the right technique for the right area. And of course, dental implant placement has become a very common procedure today in certain patients. And we have to remember that the situation is quite different. The dentogingival complex and the peri-implant tissues are very different. They're not the same, and they need different handling. If we're going to engage in dental implant treatment, we need to get our implants in the right place in order to have correct restorative outcomes, but also good maintenance outcomes. Because if the implant's in the wrong place, we have problems. And that placement, we have to remember, is not just 3D, it's 4D. Buccal, buccopalatal, mesiodistal, vertical, so in other words the head, the height of the head of the fixture, and also the angulation. And all of these play a critical role in getting the implant into the correct position. Crown lengthening is something that very often isn't done as much as it should be, and it's a technique that can offer a lot of advantages. We can divide it into aesthetic and functional crown lengthening. Aesthetic, alteration in soft tissue contours, debulking, particularly of hyperplastic tissue, changes in clinical crown height, harmonization of the gingival symmetry, and reduction to some extent, depending on the case, in excessive gingival display, while functional crown lengthening facilitates intra and extracoronal restoration to allow Dr. Cleary to get his ferrule effect and provide access to restorative margins to make a good impression, increased clinical crown height, and of course increasing the retentive potential. Crown lengthening techniques may be via gingivectomy, external or internal bevel, periodontal flap procedures like the replace flap, the apically reposition flap, and we may engage in getting our burr out and engaging in osseous recontour where we need to move that margin apically. There are also limited applications for certain non-surgical techniques. But we do need to be cautious with those. In any exam, we need to know the names, the markers. We need to be able to describe where is the mucogingival junction. We need to be able to discuss that with our examiners in detail. You should know what the biologic width is, the junctional epithelium and the connective tissue. And then when we look together, it's the rule of 3 millimeters, a millimeter of connective tissue attachment, a millimeter of junctional epithelium, and a millimeter of sulcus depth. So in other words, the distance from the restorative margin to the alveolar crest should be, in general terms, at least 3 millimeters, and that's been well documented. In terms of considerations in crown lengthening for aesthetics, we need, particularly in young patients, to assess things like the extent of the aesthetic issue, lip smile lines, tissue quality and condition, the biotype of the tissues. What are the patient expectations? What are the potential complications? And what is the probability and predictability of achieving success? And when we're doing that in the aesthetic zone, that is important that we get it right. So I think my computer's gone into free fall. Does it auto cut out when we Sorry, my apologies for 1 second. Yeah, it's endodontics. You see, it does it every time. It slows it up, right? Just to remind you that, I should never talk about endodontics because I know nothing. I'm from Barcelona. But, when we're making a periodontal diagnosis, we need to consider, is this primarily a periodontal problem, or is it possibly an endodontic problem? Is it a vertical root fracture? Is it a resorptive defect? What is it? So please bear that in mind. And supportive therapy is the key in terms of long-term success in periodontal treatment. And because of the nature of the disease, we need continuous monitoring of treatment. So Eddie will be glad to hear that the horse has cleared the final fence. And I'm glad to see that none of you fell asleep while I was flogging my hobby horse to death. You've had a great day, you've had a great course, you've had some great speakers, and I'm delighted to be able to present to you. I have to say a few things though at the end. We have a new dean today, a shiny new dean. Let me tell you, John Marley, when I took over as dean, my hair was your colour, and look what it's done to me. And hopefully you'll maintain your colour a lot better than I did. John, I wish you all the best in your term as dean, and we'll all be there to support you, and I know you're going to do a fantastic job. Can I say also to our outgoing dean, John Walsh, a job fantastically well done. A great 3 years at the helm of the faculty. I know how tough it can be. He's done a huge amount, and he's done a huge amount for all of you in the audience. So well done, John. Of course, also in the background, we have our CEO, Peter Cowan, another previous dean, Sean Sheridan, who's our international man in Havana, as it were, and our secretariat, Fiona, always behind the scenes, always supporting us, and being the interface with you in the office. Thank you very much indeed, and good luck.
Thanks very much, PJ. What PJ didn't say was when he took up as dean, he was actually bald and his hair grew during his deanship. So John, I think you have a lot to look forward to in that regard. I'd like Dean John Marley to give the closing remarks, and again, if you wouldn't mind filling out the feedback form, please. Thanks, Dean.
So, thank you very much. It's been a long day. That's the easy bit, isn't it? You now have to go away and read it and revise it. So, on behalf of the faculty, I wish you all here in Dublin and all our friends and colleagues abroad the best of luck with the exams they choose to take. I hope you choose to take them with ourselves. I hope you found today, whilst hard and intense, worthwhile, and you'll have a suitable period of reflection on that. The drop box should be brimming over with handouts as and when you choose to call them down. Those of our friends abroad who, for a variety of reasons, didn't pick up some of the transmission today, I understand that will be available to you next week, and our office will let you know about that. There shouldn't be a problem with that. Thank you very much to all the speakers. I'm sure you saw in them the expertise that comes with time and effort, and in some cases many years of practice. And on that count, thank you very much to the last of the speakers, particularly PJ. Whilst I'm blessed with darker hair, I don't have that much. So I don't think it'll be growing back anytime soon. So have a good weekend, safe trip home. Thank you very much.
And thank you to Mark for doing the audio visual for the day. He made it run brilliantly. Thank you, Mark. I can take the feedbacks here if you like.